Good afternoon, everyone. I know we have a lot of attendees coming in right now to the webinar, and just wanted to welcome everyone this afternoon. My name is Helen Hockey. I am the Executive Director of the Pennsylvania Coalition for Oral Health, and we are super excited to partner with Paula DeGregory from the Northwest Pennsylvania Tobacco Control Program this afternoon to bring you this webinar. Just a few housekeeping things as we get started. The format of the webinar will be that you will be able to view the slides as Paula is going through them. If you have any technical issues, we ask that you use the chat box for this. If you have a problem with your audio or you need something fixed up from, you're not seeing the slides or any issues like that, please feel free to use the chat box for that. And the Q&A box, that would be the place along the bottom. You'll see the black bar from Zoom. If you use the Q&A box, you will be able to type questions in there. The staff at PCOH will be answering the questions as best we can as we go through the webinar. And then we will have some time at the end with our presenter to allow her to answer or address any questions that we're not able to address for you. So again, a reminder, use the Q&A box for questions regarding the presentation. Use the chat box for any technical issues that you have. This is the second part of a two-part webinar series. Many of you have taken the Every Smoker Every Time webinar, which is the first part needed. This would be the second part. If you haven't had a chance to take Every Smoker Every Time yet, do not fear, you can still take that course. It's just that some of this will touch on pieces of Every Smoker Every Time, and it may not be as familiar to you. Once that part one has been completed, the Every Smoker Every Time, there are explicit instructions on how to let us know that you've completed that, and then we will have you take a post-test for today's portion that will allow us to know that both part one and part two have been completed, and PCOH will email you a CE certificate for 2.0 CEUs. We will give you that link for the post-test on the last slide today, as well as type it into the chat box at the end of the presentation. So with that, I'd like to turn it over to our amazing presenter today. I'd like to introduce Paula DeGregory, who is the Tobacco and Nicotine Services Coordinator for the Northwest Pennsylvania Tobacco Control Program and a great partner with PCOH. So welcome, Paula. We're so excited you're here.
Thank you, Helen. I'm really excited to be here, and thank you all for attending. I really appreciate you taking the time this morning or this afternoon to attend. Yes, and as Helen indicated, this is part two of the two-part series for the accredited training for the dental community. This is integrating nicotine dependence treatment with oral health. And as Helen discussed, Every Smoker Every Time and completing its post-test will be a requirement. You can find that on livehealthypa.com. And also, as Helen indicated, some of this may be familiar for those of you who have already completed Every Smoker. I will be referencing it, and I will be repeating some of the information that bears repeating that we felt important and deserving of extra review. Every Smoker Every Time is a really wonderful foundation and provides great information on pharmacotherapy, nicotine addiction, and covers the 5 A's of intervening with and counseling with your patients really well. This webinar is designed to transfer some of those intervention guidelines into your field and work to make you feel more comfortable in both feeling like counseling patients is within your wheelhouse and providing strategies to engage patients in meaningful ways during their quit process. This webinar is being recorded and will be available by the end of the week on the PCOH website, as will the slides and links to the websites and resource mentioned during this presentation. I also want to take a second to acknowledge and thank Southeast Tobacco Free and PHMC for their contribution to some of the slide content. So, and yes, Helen mentioned, I'm Paula DeGregory, and I've been working in Northwest Pennsylvania region, providing tobacco, nicotine services and cessation and prevention for almost 9 years. And I work with Northwest PA Tobacco Control Program in partnership with Erie County Department of Health under the guidance of the Pennsylvania Department of Health Tobacco Prevention and Control Department. We also have a very strong tobacco-free Northwest PA coalition. Please visit our Facebook page. But primarily, we work largely, my counterparts and I across the state, in tobacco, nicotine dependence, and recovery program. We're trying to shift the nomenclature a little bit towards using those terms as far as nicotine dependence and recovery, because that we feel that's a more accurate description of a person in the quit process as being in recovery. Quitting sometimes sounds more, well, quite frankly, easier, but really recovery is actually what's going on. These are individuals recovering from an addiction to a chemical substance that alters their brain chemistry. We work largely with community leaders and other organizations to partner to work on policy changes from top down, bottom up, to try to move towards positive change, to create healthy environments for citizens of the Commonwealth. And we also work with disparate populations, vulnerable populations, and substance use and mental health, LGBTQ and A communities, primarily because we're seeing that these populations are the most at risk and using these tobacco products to a higher and more significantly higher degree, and therefore suffering the negative outcomes and consequences. And you're likely seeing the same thing in your practice. We work with prevention, we work with schools, systems and administrations and districts and educators to provide prevention services directly to students, and we also partner with organizations that have direct connection with those organizations as well. We support Tobacco Resistance Unit, which is coordinated by the American Lung Association, which serves to promote tobacco abstinence in our youth and helps them to advocate for their own health and well-being relative to policy changes, and to sort of educate the public and other peers about the marketing strategies that the industry, both big tobacco and vaping industry, use to sort of entice youth to use their products. We also work on outdoor areas to try to eliminate exposure to secondhand smoke, particularly for our youth in areas where they're playing with the young lungs of play. You may have seen these signs around your communities. And we also advocate on local through the state level to try to promote changes, again, to protect and our Commonwealth people in the Commonwealth to be in safer environments, from everything from increasing the purchase age to purchase tobacco from 18 to 21, which we had a recent success, to trying to get a more comprehensive Clean Air Act in Pennsylvania that would eliminate exemptions. And I can talk more about that later if you have any questions on that subject. But primarily for the scope of today's webinar, I wanted to focus on trying to improve the knowledge base of health, and specifically oral health, and the risk factors related to tobacco and nicotine use, and try to give you a better understanding of recovery treatment options that are available, and also highlight the new billing and coding structures that have been recently adopted. Try to promote awareness of the burdens of costs on both providers and patients, and to foster a culture of nicotine treatment in the dental community and cultivate professionals that are champions. And at this point, I want to thank those of you with whom I've worked over the years that are champions and have been leading the charge to try to bring cessation and recovery treatments available, specifically PCOH. They've been wonderful, and I've worked with MCO, managed care organization reps over the years, dentists and dental office staff. So thank you for doing what you've been doing, and keep on doing it, and hopefully we'll incite some change. One thing, this statistic here in italics, this is mentioned in Every Smoker Every Time, but one that definitely bears repeating, as it's something that's motivated me over the years, and that is that most Pennsylvanians and nationwide, people that smoke want to smoke to the degree of 70%. And I want to say that this may that figure, that 70% may appear to fly in the face of what you feel is true. In other words, what your patients are presenting. You may not feel like that's accurate because you may be getting some pushback or resistance to any time you may have suggested that change. But I want to share a story with you. When I first started doing tobacco cessation, my first event, one of my first events was to present a table at the Crawford County Fair, and I set it up promoting cessation class and tobacco cessation resources. And I noticed at one point there was a gentleman walking towards me. He was about middle-aged, and he was with what I assumed to be his wife and daughters. And he saw me first, and he saw the table, and his eyes sort of lit up, and he started walking purposely towards my table. As soon as everyone else in his group noticed what he was looking at, they immediately started teasing him and ribbing him and elbowing him and laughing and slapping on the back and saying, "Oh yeah, right, you're gonna quit," like, you know, and just, it was in a loving way in a way, but it was still really not supportive of him. And like, right, that's gonna happen. You've tried so many times before. And within an instant, I saw that light of hope change to shame and guilt to one of defeat. And by the time he made it over to my table, he was pretty well defeated. I did my best to encourage him and offer him support and try to encourage him to register for the class. But my point is, you know, maybe next week he'll walk into your office for a cleaning, and maybe you're that next point of contact where you can provide some really positive reinforcement to help urge him to make that change. And that's another touch point. And moreover, you're going to have occasion to see him again. So you're uniquely positioned to be able to provide positive support over and over again. And icing on top of that cake is, as of August of 2020, you are now able to bill medical assistance patients to promote those changes. And again, the 70% may fly in the face because we see statistically in Pennsylvania, only about 53% of that 70% will make a quit attempt. But knowing that you as clinicians, what you say matters. Not only does it matter to incite them to make a change, it can also help promote them to remain abstinent. So what can we do to shift that change, that 70% in their heart of hearts? What can we do to motivate them to close that gap? And some more support of the thought that oral healthcare professionals in particular matter. When they use a quit line to aid them, we see some significant advantages. And I want to take a moment. We are going to be talking about the quit line a little bit more in depthly later, but I wanted to say that while the quit line and quit lines across the country and in Pennsylvania can stand alone, they work so much better when it's in unison with that network of support. Just like that gentleman, you know, I could be that first touch point, you could be that second touch point. The quit line and you can continue to remain touch points throughout the quit and recovery process. And just here's some statistics relative to the state of Pennsylvania on smoking use. And this is post the latest increase in taxation on tobacco products, which happened in 2016, that increased a pack to $2.60. And again, just some more resource information for you that you can bring to the table when you have discussions with your patients. A lot of times we can make better discussions or have better discussions when we feel more educated about the subject. So that's just there for you as a resource. But just continuing on with that fact about the cost of cigarettes, it has been a motivator for people. And again, this could be something that you can use with your discussions with patients on allowing them a piece of information that might cause them to make a change. You know, right now we're over $8 a pack, and I had a woman not too long ago when that increase was made, actually in 2016, come to my class because she and her husband did the math. They both smoked a pack a day, and they realized that they could take their entire family to Disneyland for a vacation. So again, another piece of information you might be able to bring to the table, not to mention the billions of dollars in healthcare costs every year in healthcare and lost productivity, plus the cost to the individual for ER visits and dental appointments and the like. And then, of course, this is stressed in every smoker, but of course bears repeating. This is the leading cause of preventable death and disease in the United States. And so not only are there economic costs, but there's cost in life. And this includes 41,000 deaths from secondhand smoke. And I want to say too that for every person that dies, at least 30 people will live with a serious smoking related illness. And I mention that because I will hear, especially from my young adults that smoke or use tobacco products, oh, well, you got to go sometime. Yes, that's true, but what about the quality of life? It's very easy to dismiss the effects that we that happen within the body because we don't see them. They're happening internally, and we don't make that connection. But this is an opportunity for you guys to make that connection because you probably are seeing it. You're seeing the direct impact, negative impact of use of these tobacco and nicotine products on the oral and overall health. So that's what I'm trying to inspire by this webinar, is to get you to help connect those dots with your patients. Another short story, if you will, I used to do brief interventions with people admitted to a local hospital, admitted with a history of tobacco use. And there was a woman there who was admitted because she had pneumonia. In fact, she had chronic pneumonia, but she never connected the fact that she had pneumonia every year with her smoking. Moreover, she was watching on the television. It was just the time when the opioid crisis was really making the news. And there was a story on heroin addicts. And she literally turned to me and said, I can't believe people put that poison in their body. So to me, and she really did not see the connection. And that's true of all of us. We sometimes will, ignorance is bliss. And when we have a behavior that we like or addicted to a substance that makes us feel good, we fail to make those connections. So if you can be in that position where you can connect those dots for your patients, that's also an inroad for you for discussion. And I'm sure you're seeing these results with oral health to make those connections and to promote change and try to guide them in that direction. Oops, I'm sorry. Well, again, here's more motivation for you. And talk about quality of life. This woman here, I actually met her at an event a few years ago, an advocacy event in Harrisburg. And we had finished meeting with our legislators, and somebody was taking lunch orders, and they asked her, and she just demurely said, no, thank you. And I hadn't noticed until that point that she had a cooler, and that cooler contained food that she could eat. So again, just the devastating effects it can have on your quality of life that you can maybe bring to the table. I do want to point out, likely you're aware of the statistic that about 90% of oral cancers, the front of the mouth cancers, are due to smoking, but the back of the mouth cancers, we know that 70% of those are attributable to HPV. And I want to mention HPV because smoking and tobacco use, nicotine use in general, is also a risk factor for HPV because use lowers the body's immunity and ability to fight off infection. So I would be remiss if I did not also make the connection with another infectious disease that we're currently struggling with, and that is obviously COVID-19. And not to mention the lung impact, the immune lung impact with use relative to COVID-19. And again, you're likely seeing all this, nothing new to you, but I just want to put it in the context of just making you feel comfortable with connecting these dots and bringing this to the table when you talk to your patients. Again, 70% periodontal disease. We know this. So again, more ammunition, as it were, for you to have that discussion. I threw this slide in here. I don't know if any of you are seeing this. I know that we see this in Erie in particular, in the Northwest region. It's a substance called gutka, product of Middle Eastern cultures. What I wanted to point out about this is that you see the gentleman here with the staining. That in their culture is a sign of status because it takes a while for that to happen. So just be aware if somebody presents with that, you could run the risk of offending them if you said, oh, we're going to take care of that stain and get you looking great here, not to worry. So I just wanted you to be aware of that in case this is something that you're seeing. People use it for pain relief and to give them a feeling of euphoria and as a stimulant. I do want to spend a little bit more time on secondhand smoke than every smoker does, because for a couple of reasons. Well, we all know that obviously it contains most of the dangerous chemicals, toxins, and carcinogens that firsthand smoking or tobacco use does, and that also then results in the same negative health outcomes. But I wanted to just remind you all of the effects it has on children in households smoke, relative to the rate of caries, and also transferring that bacteria, the caries causing bacteria, not to mention the health effects on the young children in terms of increased risk of asthma, learning disorders, and sudden infant death syndrome. Infants can be especially at risk because they breathe more per minute, so there's a concern of higher intake of harmful chemicals to still developing lungs. And also I wanted to connect for you that if you are seeing patients that smoke, or grandparents or people that live in households that smoke, that this could be further motivation for you to bring to discussion in terms of the health and well-being of their children. I don't believe that parents are actively harming their children, but again, there could be a situation where they're just simply unaware. So some education on your part may promote them to make those changes for the health of the entire family. Third-hand smoke isn't really discussed in every smoker, and I wanted to light on that as well, for the same reason as it can be a source of ammunition or motivation for your patients. This is something a lot of people haven't heard of, and so this is something, if you've ever gone to a smoker's household and they've removed a picture from the wall, it's that you'll see a frame in brown on the wall, or when smoker comes into your office and they're not actively smoking, but you can smell, you can tell they're smoking. Well, it's still toxic, a mixture of toxins that can be potentially harmful, especially to infants. And in fact, when we work with households, if we can't encourage the people to quit smoking, we at least encourage them to absolutely smoke outside, and then also to wear a jacket that they remove and then wash their hands before they touch the infant or children, because those toxins can be absorbed through the skin membranes. And also, of course, any pacifier or things that are on flat surfaces can also transfer. Children learn through putting things in their mouth, so that's something that we should be cognizant of as well. Every smoker does really do a nice job of the cycle of addiction, so I'll leave that to it. I just wanted to re-emphasize why it is so difficult to quit. There is that chemical release of dopamine in the brain. It's a really fast reaction, even faster than intravenous. And it's so easy to get, even easier than alcohol. I mean, you can go to your drugstore, gas station, and there it is. And it's not illegal. And for the most part, it's relatively socially acceptable for those populations that I mentioned earlier that we're seeing, especially considering the fact that I've been told more than once from clients that advise that they took up smoking when they were in rehab. It's a very social thing that happens in those settings. There are meetings where people are drinking coffee and smoking. And I do want to reassure you that my colleagues across the state are working really diligently to try to make a shift in those cultural shift that, and try to get a change there so that we have more of those facilities working towards abstinence from all substances, including nicotine. Every smoker does really do a good job with taking you through the impetus of vaping and e-cigarettes in the country. I did want to look further at it specifically and particularly because it leaves off, every smoker leaves off around 2014, and a lot has happened, unfortunately, negatively since then. Primarily, I want to highlight the advent of a product called Juul. Likely you've already heard about it, but Juul really hit us hard and fast and made a significant negative impact on the health and well-being of all of us, but particularly our youth. Just to give you an idea of how significant and how quickly its importance spread, Juul became a verb, juuling, almost overnight in our vernacular, whereas it took Google 9 years to achieve the same status. So just a little bit of an indication of how much of an impact that device had. So much so that since 2014, we saw a 900% increase since e-cigarettes themselves were introduced. But with Juul in 2017, we saw dramatic increases. We're talking 78% in 1 year in high schoolers alone. To go back to this slide, we now, since 2014, we've now started to categorize these devices in terms of generations, and I'll speak to that more in a minute. But just to linger on Juul for a minute and the impact, it just kind of was ubiquitous across all demographic lines. We saw kids that normally wouldn't fit the quote unquote mold of whom you would typically think of as using cigarettes. These were kids that were sort of college bound and didn't realize there was any harm. In fact, they were marketed that way. They weren't even perceived by teens, educators, or adults and parents as anything harmful. They weren't perceived as even an e-cigarette, let alone a cigarette. They didn't look like an e-cigarette, and they were promoted as this cool techie device. And they were able to get a whole generation of our youth addicted. Here's those statistics again, and you see, and we also are seeing an uptick of traditional tobacco use in cigarettes now, because of course, once you get addicted to a substance and you need that nicotine, it doesn't really matter where you get it, so you'll use a cigarette. So when we look at adult use of these products, we're seeing that it's to a lesser degree, and we're also seeing that that it's being used dual use. The FDA has done some regulation, I'll get to that in a minute, but relative to e-cigarettes as a safe or effective method to help smokers quit, they have not determined them to be such. And we still go back to our nicotine replacement therapies that are proven evidence-based, and I'll highlight those a little bit later. But going back to this idea of them being used as a step-down tool or as a safe alternative to smoking, that's been a dialogue that's been going on for a while, and may have been one of the reasons the FDA didn't come in immediately and clamp down on these, because everybody hoped that this was going to be sort of that partial silver bullet that was going to reduce harm. But we're quickly finding that, and all the evidence is suggesting that it's not the case. And as far as step down, a person really has to understand their level of tolerance relative to how much nicotine their body is used to. As I said, every smoker really goes into the cycle of addiction, but just to remind, or just to provide a backdrop for this slide, when a person becomes addicted, there's a level of nicotine that their body's used to that they have to have in order to feel normal. So for example, if a person smokes a pack a day and they want to use an evidence-based step-down tool, we could suggest something like the 21 milligram patch, because if they smoke a pack a day, they're getting about 21 milligrams of nicotine in their system. So therefore the patch will help keep their withdrawal symptoms at bay while they taper down. Well, if you don't understand that, you may be using a device that doesn't give you enough nicotine to satisfy your craving. So you're going to then dual use. Conversely, when we talk about dosing in your setting, and we'll get there, you're going to need to know that as well so that you can accurately prescribe. And I'll talk a little bit about that later when we get there. But back to the vaping epidemic with our youth, the FDA did not do any more regulation, even though I believe April of 2019 they were deemed the authority to do so. So to date, what they've done is they've increased the purchase age to 21. That was in December of 2019. Pennsylvania was a little bit ahead of that curve. In November, we made that change to law. And they did in January ban flavoring. However, they did not include menthol. And there were a couple exemptions. They exempted disposables and open tank systems. And I'm going to get to that in a minute. Suffice to say, it was a little bit too little, too late. Even without the exemptions, our youth are very adept at being able to maneuver closed systems and adding flavoring to those. But again, I'll get to the exemptions in a minute. This is just a brief look at just a shift, just to give you an idea of the marketing involved here. 2014, we can see before the advent of Juul, it was definitely marketed to older users, tobacco users, looked like a cigarette. Dramatic shift in 2017, a lot younger crowd, and it's just more like a fun, high-tech device. And in fact, there's record of executives from Juul visiting schools where teachers weren't present and talking to the youth and saying that explicitly these things were safe. This is covered again in every smoker, but just to reiterate, all these devices are basically the same. There's a battery, an atomizer, cartridge that holds a liquid, and a mouthpiece. When the person draws, it ignites, or they click on the battery to ignite it, and it turns the battery, heats up the coil, the metal coils, and it turns the liquid into an aerosol. A lot of people are still under the impression that this is a harmless water vapor, when in fact it is actually an aerosol. And those of you, I don't know how many of you remember, but in 1978, the CFC, well, I'm sorry, let me go back. The aerosol was banned in 1978 as the CFC emissions depleted our ozone layer. So again, probably not something that we know is going to have a positive impact when it's breathed into the lungs. Moreover, when a person breathes in, most of what they're breathing in, 90% of that is chemicals, and only about 10% of that is water vapor. So this is just an example of many, many products that are out there, and they have progressed in form and efficiency since 2014. We had our first generation I mentioned earlier, the disposable e-cigarette, looks like an e-cigarette. Second gen with the vape pens, you filled the cartridge with e-juice. And I'm not going to spend too much time on this. If you have any questions at the end, that'd be great, but I could spend an hour on this stuff. But for the purposes of this webinar, I'm going to just keep going here. But I do want to mention this is third generation, the open tank system that is exempt from the flavor ban. And incidentally, these are systems these are the ones that you see these huge voluminous clouds from, and there's a whole cottage industry or cottage industry surrounding these. You can go online and buy different pieces to kind of turbocharge, similar to turbocharging an engine in a car, to get that big cloud. So what we're seeing is there's things called cloud chasing. You can go on YouTube, and there's some really beautiful examples of cloud ballet, I call it, set to music. It's really enticing to youth, coupled with the flavor that's allowable. And again, there's that with those big clouds, luminous clouds, there's sporting events where there's competitions that are funded, sponsored. You win cash prizes, and they're recorded, and they have live followings. And then again, the fourth generation, which are the closed systems, these are exempted. And this is the Juul that I talked about on the left there. And you can see to the left of that is the pod that you insert. And that pod, incidentally, contains as much nicotine as an entire pack of cigarettes. However, it's 4 times as strong. So not only are these kids getting a ton of nicotine, it's even stronger and more concentrated rates. So I just mentioned that we have a ban on flavoring. So Juul has taken a hit relative to that, but in its height of its popularity, it did spawn a lot of copycat devices that had that closed system that were cool, sleek, high-tech design, all easily concealable, and you as parents or educators would mistake it for something that's not a vape pen. But as I said, these products are now, the closed systems are now regulated, so they cannot allow flavors. But don't worry, because where there's a loophole, there's a will, and where there's a will, there's a way. And the industry has responded with what I'm terming as regeneration of the disposable e-cigarette. Because as you remember from the earlier slide, disposable cigarettes are allowed to have flavors. So they are around in abundance. Puff bars, Cali bars, Pin, as you see here, these are all allowed to have flavors, and they're appealing to youth. Moreover, these products, some of them have even higher concentration of nicotine than did the Juul. And this one, I pulled this because I had got an ironic chuckle off of it. It's called the Thinker, and you notice it touts that it has a filter that can be swapped out. Many of our youth we know share devices because of cost concerns, because they get expensive, or just because socially they share them. So this is for the Thinker, the conscious, aware person, conscientious vapor. And I highlighted their advertisement context that says it also helps prevent the spread of germs and viruses, and I'm sure you can make the connection to what they may be alluding. And again, these things are on sale, which makes them more appealing for youth to purchase. Here's just a quick overview of some other emerging products. Again, designed to entice, and you can see the vape wear there, where the hoodie, the drawstrings used as the inhaler or the vape conduit. And there's many products out there. As I said, I could spend an hour talking about this subject alone. But moving on, the question, are they safe? They're not for especially young adults, youth, pregnant women, or adults who don't currently use tobacco products. And obviously, more research is still need to be done to understand the long-term effects. But as I said, the more we are learning, the more we're realizing that it's just not good and it's not getting any better. And of course, there's secondhand vape is also unsafe. If you remember that particulate matter I mentioned, or I don't know if I did, but when that the heating element in the battery of the device heats up, it's metal. So when it heats up and when the person inhales the chemical vapor, with it they're breaking some particulate matter from that coil, lead and nickel metals, heavy metals, and that's showing up in bystanders. That's how we know that there's a transference or that there's secondhand vape exposure. And that those ultrafine particles, there's anecdotal evidence to suggest that it's because they're so fine, they're being breathed deeply into the lungs and into the lower chambers, and causing symptoms that are very comparable to black lung disease that we see in coal miners. And again, there's all these other chemicals, and because these aren't regulated, there aren't any regulations, we just really don't know what chemicals are entailed, but those that we have been able to investigate, we know they're not good. In particular, nicotine, which we know is damaging to the developing adolescent brain. In particular, it creates pathways that can lead to other substance addiction, cause learning issues and focus issues. And specifically, if you're in class, if you're in school, before COVID, during the day, and you're going through withdrawal time and time again, you're not going to be focusing on that math problem that's on the board. So, of concern. And also, there's linking the high concentrations of nicotine to increase in seizures. Many of them we feel are underreported because they just aren't recognized. They go unnoticed. And of course, vaping and lung health. Before the advent, or before COVID-19 took center stage, which it rightly should have, we were seeing a lot of lung injury, lung health due to EVALI. That's the e-cigarette vaping associated lung injury. And the CDC had been conducting ongoing investigations, but again, with the advent of COVID, they shifted their energies, but it did cause a lot of illness and death throughout the United States, and that's still occurring. And so we saw 80% of them in those under 35, which sort of jives with the fact that we know that that's our biggest population of use is that demographic. And 75% was due to THC and E-acetate, which is a chemical that, a substance that's absolutely fine to ingest vitamin E tablets or to apply topically for skin concerns. However, it's obviously not something that's meant to be breathed in. It's going to have negative effects. A good analogy I use especially when I'm addressing youth, I'll mention water. Water is one of the healthiest things that we can do, that we can intake into our bodies. We know it just promotes all sorts of health benefits. However, if we were to breathe it in, what happens? We drown and die. So trying to make that connection is particularly in youth and people that use it, that just because it's okay to ingest it, it's not okay to inhale it. And I also always try to ask the youth that I'm dealing with is what should be going into the lungs, and they typically answer a combination of fresh air or oxygen. So yeah, bottom line, anything other than fresh air into the lungs, probably not going to be of benefit. And likewise, the researchers tell us for EVALI that the other substances may be at risk as well. While EVALI is one, there could be other factors, and because we don't know of all the chemicals you're breathing in, it could be something else that causes negative effects. So vaping and oral health, again, just bringing this within context to give you some ammunition to discuss these topics with your patients. I'm sure you're already seeing this. I've been told by dentists in the field that you've made these connections already, but because we're evidence-driven, we're waiting for more and more research, but it's coming in and it's supporting likely what you're already seeing in that vaping in particular, because of its vasoconstriction tendencies, is having a negative effect, and we're seeing an increase in periodontal disease and caries. Also, the connection that you guys see with systemic or system changes in the body relative to oral health in general, there's support showing that this is also true relative to oral health and vaping and tobacco use and vaping use with system changes in the body and negatively impacting overall health. And, you know, these are concurrent comorbid issues here, because we in the tobacco world have made those connections as well. So again, this is all definitely within the same scope of care and within your wheelhouse. And just recently, as of Friday, we're seeing more support of both of those things just discussed, that system change and the periodontal disease. But as of Friday, a new article published, or a new study published, actually indicates that even after a few months, the healthy mouth can be pushed towards serious periodontal disease, only a few months of vaping. So again, more indication of what you're seeing is accurate relative to vape use and nicotine use. This one was interesting to me relative to the sweet flavors that we see in vaping products and how it's associated with the effects of gelatinous sugary candies and acidic drinks. And also there's some evidence that suggests that the sweet flavor strengthens the addiction as the user perceives a greater satisfaction. In other words, there's that release of dopamine that the nicotine is giving off, and then you couple that with the brain really getting gratification from that sweet flavor or experience. So it's serving to strengthen the overall addiction to the nicotine. And we're seeing that predominantly in youth, and that's where our concern is. So what can you do? Hopefully I provided you some and reminded you of some things that you already knew, and provide you with some new information that you can sort of try to bring together to hopefully move that needle and close that gap of the 70% from that 53% in PA who make the attempt. So what can you do? What are you doing now in the field or in your office, and how can that be improved upon? And how can you be that catalyst for positive change? Well, the first thing, you're on your way. Congratulations, you're becoming trained. And the Every Smoker Every Time, as Helen indicated, that will allow you, once completed, to apply to the tobacco registry at the GHS website, and that will allow you to bill for these services. And we'll talk about that. I'll give you some information on the coding in the upcoming slides. But if you wanted to go further, and I do encourage you to do that. And again, you have been given instruction on how to get that how to make that registration application happen. But yeah, become trained. This is just the tip of the iceberg. It can give you some information to make you feel comfortable, but do the Every Smoker Every Time. There's also more in-depth training out there. The Duquesne University offers a Certified Tobacco Treatment Specialist certification course that's a combination of online and in-person, and there's one starting in July. I think it's still going, but you have to check. Integrate tobacco discussions with your with your patients, because we know that when a person uses NRT, nicotine replacement therapies, it will double their chance of success. Consider prescribing NRT and identify somebody who can do so. Often, especially since we know that our medical assistance patients or people in low socioeconomic status are ones using at higher rates, they may find cost to purchase NRT a barrier. And a lot of these medications, patch gum and lozenge, are over the counter, and it may be cost prohibitive for them. So if you can prescribe it, you may remove a barrier because you're prescribing it, may be, enable them to purchase it at a lower rate. You can read the rest of the slides. Just incorporate, do color coding. If you have electronic record keeping, try to include that so you can have discussions ongoing through the quit process. If we haven't encouraged you enough to consider billing, I'm going to show you the coding slide next, but just a rough estimate, if you were to counsel in cessation or recovery, tobacco, nicotine cessation recovery, just 10 patients per week, that could add up to about $10,000 annually for your practice. And as I mentioned, it's effective in 2019 of August, D1320, the code D1320 was added to the Medicaid fee schedule with an assigned fee of $19.33. Managed care organizations may offer some different codes, but they're all basically paying out. And also, even though managed care organizations are paying it out, it might be worth a call contacting private insurance carriers, because some of them are starting to cover it as well based on group and individual contacts. So make that call and you may be able to get a reimbursement from the private insurance as well. There's no specific diagnostic code. And you don't have to do the same day as a dental appointment. The limit is 1 unit per day, 70 units per calendar year. And this was done to match, try to get that NRT. Remember that most smokers have tried to quit, but they may not have. Remember that gentleman that approached me in the fair obviously had tried before. And even though I felt that his family loved him, they weren't supporting him in the way that he needed to be supported. So you can be that conduit of accessing NRT and also supportive counseling, prescribe no cost or low cost. And again, that high rates of Medicaid and underinsured are most vulnerable populations. Just a quick look at the NRT. I'm not going to go into it because every smoker does in better detail. I just wanted to mention a study that occurred after every smoker relative to Chantix, because a lot of your patients may have a fear of using Chantix because it had been associated with psychiatric events. But this study really concluded there were no significant increases in psychiatric events relative to patch bupropion or placebo, and that in fact it had higher abstinence rates as did bupropion and nicotine patch combined over placebo. This I just wanted to bring to your attention. We're providing you a PDF file of this. Please download it and use it as a tool. It gives you an overview that you can use in a point of reference about the pharmacotherapy drugs that are available that we know work, as well as the 5 A's of intervention covered so well in every smoker, just to give you sort of an anchor while you're talking to your patients. And we ask, just at the very least, we realize that the 5 A's may not be something that is going to work for every situation, but we ask at the very least that you ask and advise and refer. That's the AAR model, because if you simply ask, which we're all now trained to do, because it's a requirement, if you just ask and don't advise, your patient may take that as a tacit approval of the behavior in which they're engaging. In other words, well, they asked me if I vape, but they didn't say it was hurting me in any way, so they think it's okay to continue. So at the very least, ask, advise, and refer to some other entity, and I'll get to there in a second. But basically, here's some strategies, and I do want to take a second to advise that we are going to be providing you with links to videos that will show you how to conduct an intervention within the setting of the dental arena. So please take a minute or minutes to look at those over. One of them is actually AAR, but all of the others are relative to oral healthcare practice. But basically, be non-judgmental. If you remember nothing else, that's really a key. Likely these individuals have been hearing this from everybody, and as I mentioned, that gentleman at the fair, maybe not the positive way, most positive way. And they feel like they're failures and they just need some support. Ask good questions instead of just telling them what they should be doing. Be really open to what they have to say and their concerns. For example, I understand that you're concerned about using Chantix or other medications due to their side effects. However, those side effects are really minimal and they're proven safe. They require a doctor's prescription, but there are other options we can try if that doesn't work. And if we think about it, your leukoplakia is a side effect of smoking, and this is precancerous, and that can be very serious if you don't try to figure that out. So just sort of get them engaged and involved and help them work it out and get to that point. Connect those dots. As I said, that women in the hospital, they may not see it, but you do see it. Don't assume that they're there. Foster hope and compliment them on success. Even 1 hour of abstinence is a success and it showed control. Point out to them they likely had a craving while they were sitting in the dentist chair, but they were able to get through it. And with your help and with help of NRT, they can achieve lasting success, depending on where they are and their level of readiness to make those attempts. But basically facilitate a conversation with the patient that you both will enjoy. And just in any case, just try it. Just prioritize, give them the support they need, advise them to try the Quit line, 1-800-QUIT NOW, the PAQuitLogics.org, or to seek out a local service provider. We're here, there's one of me all throughout the state, and we're ready, willing, and able to provide that support to your clients. The Quit line, I don't want to spend too much time on this, but if you can take a proactive measure and get your patients signed up in the office, that would be wonderful. And again, I don't know if I mentioned this, but as of October, intake information on the Quit line, ask them, were you referred? One of the questions asked if they were referred specifically by an oral health professional. So using this can be a really great measure for you to connect directly if your efforts are having an impact on the people that you're counseling. The other benefit is that the Quit line always offers, at some degree, usually always offers free NRT. Currently it's 8 weeks, so again, another barrier removed for them. It offers reports to keep you involved and engaged with your clients, so that you can be active, have an active conversation with them. You know where they are and their status with the Quit line, where they are with their Quit. I think I do want to go back here. No, sorry. Okay. And as I said, it can give you, especially for I'm going to go back here, FQHCs and rural health clinics, these metrics can be really a great benefit for you to help see if you're meeting measures that you may have that are in line with smoking cessation or tobacco recovery, nicotine recovery. And again, the Quit line can provide you with specific demographics that you may find useful to your practice or helping you achieving just overall goals. Just quickly, you'll have access to the slide, but basically you just go into PAQuitLogics.org, you select a healthcare provider, how to refer a patient. You would go to a provider web referral, and then you would input their information. Just as a note, their information will not be stored. It will disappear after you submit the application. However, when you put your information in, it will be stored. And this is great because after you put your first patient in, you won't have to put that information again. It'll auto-populate, which will save you time. This, of course, is free. I do want to point out that due to the advent of vaping epidemic with our youth, the Quit line has established a module specifically for teen tobacco use and nicotine cessation, and it focuses significantly on vaping. This site, My Life, My Quit, also provides resources for parents educators, healthcare providers. So check it out. Also, I know that some of you had indicated that you are seeing parents and grandparents that don't know what to do. They know that their children, grandchildren, or children they're caring for are using these products. So this is a great resource for them as well. And I could talk to you more if anybody has questions about the youth and young adults. These are a particularly difficult audience to reach, but there are ways to reach them. We do have some strategies that I can share with you. But just know that they're out there. And this is a good website to help get some of that information as well. Another one, smokefree.org. They have really tailored text formats for people, and they have some for teens, moms, and veterans as well. They have chat lines, apps. Another great one for providers, healthcare providers, and parents and educators, in addition to teens, is the Surgeon General's website. With fact sheets for all those entities. And Truth Initiatives, this is quitting.com, is another wonderful resource to share. And of course, the CDC has a dedicated oral health and tobacco resources page where you can download actual and order materials that you can give to your patients. And just as a note, my colleagues and I throughout the state usually have stock of these materials that we can provide your office. So contact us as well. Oral health and tobacco resources from the ADA, they're usually frontline, and they have dedicated information and research available relative to tobacco, nicotine use, and oral health. Etude is a wonderful organization. If this topic is something that's very near and dear to you, I highly encourage you to join. This is an active conversation that's ongoing about tobacco treatment for tobacco users. And as I mentioned earlier, there are regional primary contractors in each part of the state, ready, willing, and able to provide you those resources I mentioned from the CDC, as well as when when things open up more, we can come to your office and provide you more detailed training on any, going more in depth on any of the subjects that I touched on during the length of this webinar. So I, with that, would like to end my portion of this live webinar and open it up to any of you that may have any comments or concerns or things that you'd like to bring to the table or share with us about what you're doing.
Thank you so much, Paula. That's so much good information. And I know that you haven't been tracking the chat box or anything as you've been presenting, but we've gotten a lot of great comments. I think there's a lot of valuable information for our attendees today. And Amy's going to be placing the post test into the chat box now, but let me ask you, Paula, one of the questions that came in is, let me see, how can you effectively ask questions in the advise stage of AAR? Do you have some specific examples? And I know I didn't mention it in the box, but I wanted to say that I know some of the videos that we're going to be sharing would provide some examples, but I'm sure, Paula, you have some other great ideas for the advise stage and any questions that might be relevant to ask during that stage.
Well, right. Thank you, Helen. Yes, I do believe I did to give that one example with the leukoplakia and its relative significance that it could turn into a cancer-causing thing, but just sort of advising them to think about taking action. It's of course relative to where they are in their readiness stage. If they're feeling like this is something that they want to do, and you'll have to judge that. If they sound like they're willing to make a step towards having a quit, then advise them. I would actually have them sign up with the quit line. I would get them signed up right now. I'd register on the PA Free Quit line and get them going. If they feel like it's something they have been thinking about, or they're not quite ready, they feel like too much is going on right now, then you can advise them to think about it some more and give them some materials for them to take home, and then advise that you probably are going to bring this up with them the next time they come into the office, because it is part of their oral health, and you're concerned about it, and if that's okay, you're going to probably keep mentioning it because you care about their oral health and their overall health.
Thank you, Paula. The next question I see, and Paula, I'll probably address this one if it's okay with you, was asking about, it's a billing question. So, would a PhDHP be able to bill for this code? And the way that it's set up, and I think I have this straight, is that in order to bill the Department of Human Services, it does have to be done through a credentialed Medicaid provider. So with that, a PhDHP that is working as a credentialed Medicaid provider may be able to do that. I know we don't have a ton of those in the state, but even I did want to point out that from what we understand, if you actually look at the form that you fill out to register with DHS as a cessation counselor, that the practice owner slash credentialed Medicaid provider fills out the form, but then you actually can list people within the practice who are able to do the counseling. So, if a provider has, say, 3 or 4 dental hygienists who have taken the training, then they would be able to be doing that, but still billing under that central employer as the Medicaid provider. And likewise, if a PhDHP is credentialed as a Medicaid provider with the managed care organization, of course, they would need to confirm that with the groups they're credentialed with. But it should be possible to bill out that way. That sound clear, Paula? Do you have anything to add there, or did I mess up any of that billing part?
Nope, that sounded perfect.
And then the last question we have right now, and I encourage you, if you have any other questions, please feel free to type them into the Q&A box or the chat box right now. But the question we have now from Lauren Collins is, do you know if in a teaching setting, a student can bill Medicare under a faculty person who's licensed? And I'm assuming that's Medicaid, probably more so than Medicare. And again, I believe that it would do the same, it would be the same method, that faculty person would be the credentialed Medicaid provider, so that, those who were trained, that work underneath the faculty would be able to do the counseling, but the billing would have to be going in under the school or the credentialed provider. Paula, do you know anything on the medical side about that? If there's anything about in teaching facilities where the students are able to do the counseling?
I don't, Helen. That's a really great question. I can reach out. I work. I've been working through the years with a respiratory care person at Clarion University. I can reach out to them and find out and get back to you.
Yeah, certainly. And I think probably what we will end up doing is sort of keeping a running list of sort of FAQs around this, because we know that this is a really timely issue right now, and we know that it's an opportunity for a lot of dental providers to jump on board with. So I think we're probably going to, as the coalition and in our partnership with Paula and her organization, we'd like to sort of keep a running list of frequently asked questions so that we can make sure we have everybody getting the most relevant information. And I did see another question came in, noticing xerostomia with Chantix, sometimes severe, so dry mouth. Paula, have you had any concerns or anything coming in from a non-oral health perspective about severe dry mouth with Chantix?
Yes, from clients, I have heard that. So yeah, I have heard that from time to time. But again, I would remind everybody that, take that into consideration if you're hearing that from your patient, and if there are ways that you can work to mitigate that. But also, they don't need to use the Chantix. There are so many other methods out there, and not everything works for everybody. Just as every flow of counseling is not going to work for every office, not every medication works with every person, and just counsel them to that aspect of it, that there are other methods out there, that you try the Chantix, we can try something else if you're not comfortable with it. And along with that, I always counsel my patients, no matter what NRT we're discussing, that I tell them that if it's not working, don't just jump ship. Don't just say, oh, well, that didn't work again, or that didn't work, I'm done. call me, talk to me, we'll figure out what will work and what can work. And not every dosing, I know I talked about dosing, you do have to know the dosing. You have to make sure that your patient is being honest with the amount of nicotine and some that they're intaking. And sometimes, especially with healthcare providers, they're reluctant to give the honest answer because they feel like they're just going to get beat up about it. So, you know, try to establish a rapport that they would feel comfortable being honest about it. And then even at that, though, sometimes when we even advise on what dose to take, it may be different for different people. People have different sensitivities. So it's important to not only discuss NRT, but have an ongoing conversation with them about it and touch base with them to see how they're doing with that, because it may need to be adjusted relative to dry mouth or other side effects they could be experiencing. One thing I do want to mention that I did not mention, every smoker does, but nicotine has interesting effect with caffeine use. So as a person decreases their use of nicotine, they feel the effects of caffeine to a greater extent. So a lot of times a person will confuse that feeling of the stimulation that they're feeling from the caffeine because it's affecting them to a greater degree. They may feel that that's a symptom or side effect of the quit medication. So knowing that's really helpful, again, for you to have that conversation with your patient to help mitigate the effects of the NRT versus helping them maintain a successful quit or staying on their quit path.
Okay, and I did see another question come in around insurance coverage for Chantix. And I know that we were actually in contact with a lot of the managed care organizations prior to the conversation today. And I know many of them have added it to their formulary schedule. So again, that's something that, Paula, I don't know if you want to add anything from the medical side.
Well, we do, when I have clients, sometimes they have incurred barriers relative to Chantix. I hear that some insurance companies requiring them to do use other medications, for example, patch, before they'll allow Chantix. So we just counsel them to talk to their doctors because likely they may have already tried that. So it just may take a word from their doctor into the insurance company. Also, I believe every insurance company, correct me if I'm wrong, has like an advocacy department that I usually tell clients if they can't get anywhere with their doctors to try that as well. And then, especially with Chantix, if you go to the Pfizer website or some of the Chantix websites, there are often coupons that are available for the clients, but it's best to work with your insurance companies ultimately, because that's going to be an ongoing need for at least several months. And I did want to mention something else about Chantix and the other NRTs. We always advise people to stay on them for as long as it's suggested, and sometimes even longer, because it takes a while. We're talking about people that have 10, 15, 20, 30 plus years of a habit that they're trying to break or change. And so it takes a long time to make those behavioral changes. So we need a long time for them to be on the NRT to provide them that break. So the NRTs, they're working to help lessen their withdrawal symptoms so that they can make a behavioral change. They can make an active decision about whether or not they want to use that device. And the longer the time they have that their withdrawal symptoms are kept at bay, the stronger that they can develop this stronger behavioral habits to make those changes. So and even I've had patients on the patch that have gone longer on the first pack because they just felt like they weren't ready to make that change, and that's okay. Again, it's about maintaining that dialogue with your patient about where they are and where their comfort level is on taking those next steps, because it's all a progress, right? The first is just making the decision to try, and then there's baby steps from there on, and it's just until they feel strong in their quit after a couple weeks, several weeks, then that's where you're trying to get them to where they feel strong, that they feel both that the the addiction, they've managed the addiction side of it and the behavior side of it.
Okay, that's great. And I did see one other question come in around, if a PhDHP would be billing on their own, then of course the ability to write a prescription would be limited. So I would always, encourage you to be working with a provider in your area that would be able to do that. So, you could work in conjunction with a medical office or a dental office, maybe the dental home that you refer to, and maybe work in partnership on that. It doesn't just have to be a solo approach. I think that that's something that, we forget, is that we can all work together, and we should all be part of the healthcare team. So hopefully that is helpful. And I know there's a handful of people I'm seeing having a little bit of trouble with the post test. So if for some reason, I know we just put it back in there again with the www in front of it, but we will also send the link out with the notes and the PDF after today. So we will definitely send that to you, but it did work live for me as I typed it in. So I'm wondering if maybe it's just a URL issue. So, but let us know if for some reason after you receive the link via email, if you can't access it.
Helen?
Yes.
I wanted to, while we're still talking about NRT, and I'm glad to hear that people are asking questions about that, I want to say you guys might be really primed. This could be really interesting because I don't think that your patients are probably used to you talking about NRT, or let alone prescribing it. So those of you who take that initial step, that could be really something unique and novel, and it really will have an impactful message, I think, on the patients to think, wow, this is really, they're talking to me about NRT. They're wanting to prescribe it for me. This really must be important. So I just think that. So thank you for those of you who are really considering doing that.
Yes, absolutely. I think the more that, patients feel that, there are multiple providers caring about them, it's a really good thing. So I agree 100%. So I am not seeing any other questions come in. So oh yes, one more question there, Paula. The course at Duquesne, do we have a link to that in our resources that we're going to be sending out? And
Absolutely.
could we add that?
Absolutely, it's there. It's already there.
Okay,
I
good.
recommend it. It really dives deeply into all this stuff, and I'm happy for that question. Yeah.
Good, absolutely, yes. We'll be sure, we have quite a great resource list that Paula has provided that we'll be giving to everybody, so you will have that course information. So with that, I think we are all wrapped up now. I do just want to say thank you again, Paula, to you and your organization for providing us with all this amazing information today. And if anyone has any questions for us or for Paula after the webinar, please feel free to reach out. I know Paula's information is there, and I believe everyone should have contact information for PCOH as well. So thank you very much, and I hope everyone has a great day.